So we have Bhumil Shah with us today and Dan Brown, who are our, I'm going to just call them our data gurus because they're the ones we count on for keeping us straight where numbers are concerned. So Bhumil, do you want to take a start?
Sure, I'll get started. Hopefully, we had about 15 people who have signed up. So hopefully more of them can join in the next few minutes. And for those of you who have joined, appreciate you spending your 1 hour on a Friday afternoon with us. We appreciate the interest the community has in the data. And we want you to be aware that we are here to answer any questions you have now. And feel free to reach out to us even after this call. Uh, we So as Kim said on the call, some of our team members, Dr. Pramanik is a CMIO, Chief Medical Informatics Officer. I am Bhumil Shah. I'm the Chief Analytics Officer for the County Health Department. You just heard from Kim, who's our Public Information Officer. Dan Brown, Lead Data Scientist. And we also have Chris Lynch, a data scientist, and Lisa Dimos, who's an epidemiologist on the call. Before we get to the questions, just want to give some background. Almost everything we're going to discuss today, data-wise, is available on the public dashboard. There are some elements which are not, so we're happy to go into details about that. But we try to be, as we build the COVID dashboard over the last 6 months, we've had three design principles. One is to be as transparent as possible. So that's why you will see a lot of the information is on the public dashboard. In fact, some of our own staff actually uses the public dashboard too. So, we try to be as transparent as we can. Also, but we try to respect privacy. So if any information would identify an individual, we don't publish that. And then sometimes we get complex questions about the data. And why didn't we publish it that way? But the third goal of our dashboard was simplicity. We want something that everyone can use and understand. So we try to keep it simple. And that's why we have calls like this, where we can address more complex questions. A reminder, the dashboard is available both in English and Spanish, and it's at coronavirus.cchealth.org. And this is our landing page. This is where you can go to get the latest information. This is where we share our news and updates. Again, coronavirus.cchealth.org. And a reminder, as Kim said, this is a data session. As you can see, I'm showing you our org structure. So there are people leading testing, lab, policy. We are the data folks. So we are here to answer the data questions. So if you are just want to make sure you're in the right meeting. And before we get to the questions, I just want to set some share how we collect this data. So for cases and testing data, these are the 6 steps. The way this works is the individual goes for testing at a community site or at a private clinic. That sample gets sent to the lab. The labs are required to report all their all their results, positive and negative, to the state. We as a county have access to that data from the state. We use that information flows to us, and we use that to generate the dashboards as well as for internal decision making. And then that information also becomes available to our case and contact tracers to follow up with cases. So as you can imagine, there are 6 steps. So there may be a delay in reporting, especially death data, which is more complex. So there is a longer delay in reporting. And then the second element is the capacity, right? How many hospital beds we have, ICU beds we have. Each hospital across California is required to submit this data daily to the state, what their current capacity is, how many beds are occupied, how many people in ICU, how many ventilators. All that gets reported to the state daily. And then we rely on that information to, again, both for internal decision making as well as what we publish on our public dashboard. So let's jump into the questions with that background. I have tried to group the questions logically. So we had a number of questions about ICU capacity. So I've grouped the 5 questions we had about ICU together. I can understand why, because we heard about a week ago from the state, from the governor, about additional restrictions, what he calls the emergency brake based on ICU capacity. So knowing that this is an important measure, if you have been tracking our dashboard, if you have seen it this morning, on the hospital dashboard page, we have published both what the remaining ICU capacity is in Contra Costa, as well as what the remaining ICU capacity is in the Bay Area. Uh, and, I'm happy to show you the screen where this is. So if you can still see my screen, oops, sorry about that. If you can still see my screen, if you go to coronavirus.cchealth.org and click on hospital dashboard, scroll down a little bit and go to the ICU section. And this is where you will see what the remaining capacity is in Contra Costa as well as overall Bay Area. Just keep in mind that there are some timing issues when the state pulls this data and when we pull the data. We pull it once a day. So we may be off by a percentage point here and there because of the timing issue. So the first question was, will you update the dashboard to show the ICU beds available in regards to the regional stay-at-home order? So we just did it this morning. Second question was about the ICU capacity. Is it reported per county in the Bay Area and how often is it updated? So we, like all our dashboard, we update them once a day at 11:30. And as you saw, we are publishing both our own county, Contra Costa's ICU capacity, as well as the Bay Area. If you want to know other counties' ICU remaining capacity, state has its website where they also publish for every county in the state. So that's another good resource. The third question was, why does the total ICU bed count change drastically between days? So as I was explaining earlier, right, each hospital, the hundreds of hospitals in California, every day they're required to report their total ICU capacity, their ICU occupancy, and a bunch of other information to the state. And we use that for reporting. There could be a couple of reasons why the bed count changes. Because what we are reporting is not just the number of ICU beds, the physical beds, but beds that are staffed or can be easily staffed. Because the concern amongst the health officer also is not physical beds, but do we have the nurses and the doctors to uh, to staff those beds? So what we are reporting is how many ICU beds are available and are staffed or can be easily staffed with the resources each hospital has. And as you can imagine, as staffing can change every day. People fall sick, call in, take a day off, various other reasons, right? So that's why the numbers we've seen, they fluctuate. Go up by a few every day, go up, drop sometimes by a few. The fourth question was, I noticed two things after downloading your hospital data. There is no data for ICU variables before July 21st. So one, thank you for noticing. Second, the reason, so as I said, we use the data that each hospital reports to the state, and we report using that data. What happened back in June, I believe it was June 23rd, the state changed the definition of what needs to be included when each hospital reports ICU capacity. So they also asked the hospitals to include neonatal ICU beds in that count. That happened in around June 20th. And then around July 21st, the state realized that we should not be counting neonatal ICU beds because really those beds cannot be used for adults, right? So they ask the hospital to exclude neonatal ICU beds. So given that the definition itself change of what we are reporting, we decided to only report data July 21st onwards, because comparing data uh, pre-July 21 and post-July 21 was like comparing apples and oranges because it included different kinds of beds. So that's why our data includes ICU beds after July 21st. And the last question about ICU or hospital capacity is, what is our current hospital capacity in Contra Costa? So, it's a simple question, but I'm going to give you a complex answer. There are different ways of measuring capacity. One way is what are the number of licensed number of beds each hospital has. And as you know, we have 8 hospitals in the county. We have 3 Kaiser hospitals in Antioch, Richmond, and Walnut Creek. We have 2 John Muir hospitals in Concord and Walnut Creek. We have a Sutter Hospital, and we have San Ramon Regional Medical Center, as well as we have Contra Costa Regional Medical Center in Martinez. So there are 8 hospitals. Uh, the total licensed beds is close to 1,800, but then that's the overall capacity. But that does not include, are these beds staffed? And the licensed bed also includes some of the post-op beds. So with staff excluding post-op and ER beds, we are about 1,200 or so beds. And then finally, each hospital has a surge capacity plan. The plan is to add more beds if they need to. So if we add that, there are additional 300 beds or so that can be added. So I know it's a simple question, but the response is we have 1,200 beds with a capacity to add up to 300 with the overall license capacity of 1,800. All right, I'll keep going. We'll have a chance to pause and then have a more interactive question answer. So once we go through these questions that were submitted, we'll open it up and we can have more back and forth. The 6th question that was sent to us was, I would like to understand the data sources for residential long-term care facility. As you know, there are a number of skilled nursing facility and long-term care facility in the county. Our public health department has created a line list of staff and residents at each of those facilities. So we've tried to build a comprehensive database of individuals who are either living or working at those facilities. And then, so given that list that we have, as cases get reported to us, we're able to match them against that list and figure out how many cases are tied to a long-term care facility. The other way we also get this data is based on testing. So often when there's an outbreak, our own public health department will go to those facilities and test so that we know all the testing that occurred belongs to that facility. So there are a couple of ways we track all the testing done using that line list, that comprehensive database of staff and residents. And also we rely on our own staff going out and testing at those facilities to report the data at both the skilled nursing facility as well as long-term care facility. The 7th question, question number 7, is why are you not differentiating community acquired versus long-term care facility numbers? Over 300 outbreaks doesn't tell us actual case numbers. So let me answer the first question first. So again, if you go to our public website, we do have a dashboard that's dedicated to long-term care facility. So if you click on the long-term care facility button, you would see the total number of cases till date that are associated with the long-term care facility. So of the 28,000 cases that we've had so far, roughly in the county, 1,300 of them are associated with a long-term care facility. So I hope that addresses the first question. The second question and the question after that are related. So I'll read question number 8, which says, what's up with the long-term care facility data? On November 30th, we reported 354 active outbreaks, and then it went down to 24 on December 2nd. Was it an error? Huge discrepancy. And we appreciate how our community is tracking this. Yes, it was an error. And in full transparency, as I said, we maintain that roster. We also maintain a roster of all the facilities in the county. And accidentally on November 30th, one of our staff went in and entered duplicate, copied the same facility again a few times. And that result, so we had a number of duplicate records on that day. So when we reported, we double counted some of the cases, and that's why number of outbreaks grew. We realized that the very next day. So one, we removed the duplicates from the list, and then going forward, we have added some checks in the database, so that way we don't end up creating duplicates again. But I appreciate and I'm impressed how closely our community is watching us and also keeping us accountable. So thank you. Question number 9 was, what's the overall test positivity rate in the children in the county? So I'm going to pass it on to Dan, and he has pulled this data. Dan?
Hi. Yeah, so if you could go to the next slide, it has the numbers on it. It's a pretty straightforward question. We have children broken down on our internal dashboard by several different age groups by 5 years each. So 0 to 4-year-olds, 5 to 9-year-olds, 10 to 14-year-olds, and 15 to 19-year-olds. And you can see in the right column here, the percent positivity. In general, we see that that percent positivity is higher among children. I think because they are in general kind of less likely to be tested. You can see that our youngest population has only 12,000 tests, while compared to our teenager population, 15 to 19, they have 35,000 tests. So just much more likely to be tested. And if we're testing less, it's kind of more likely that we'll catch that we'll have the higher positivity, that we'll test more of the people who actually have, who are positive for the disease. But when we look overall at children, if I look at 0 to 14 years old, depending on how you want to calculate it, it's 7.7%. And if we include all the way up to 19-year-olds, then the test positivity is 6.7%.
Right. Thank you, Dan.
Mm-hmm.
I'll go back. Question number 10 that was submitted. Actually, Dan, you want to keep going? The next question was about symptomatic versus asymptomatic.
Okay, so symptomatic. This is a little bit more of a challenging question to answer because we don't always get symptomatic information on our positive tests. The way that we receive information is through the places that did the test, and they have the opportunity to report whether or not someone is symptomatic, but that's not always done. So you can see here, this is kind of all of our positive tests in the county so far, and 68% of them we don't actually know whether or not the person was symptomatic. But if we subset to just the 32% where we do know whether or not they were symptomatic, we see that 27% of our cases reported having symptoms. And I think one thing that's important to remember here is that doesn't necessarily mean that this 27% is the percent that ever had symptoms, because we may have asked people this question prior to symptoms showing up, especially if someone was identified as part of a contact tracing exercise where they may be very early in their infections. Then maybe they got symptoms later, but at the time in which we asked this question, they didn't have symptoms yet. When we looked kind of at the literature of other people who've tried to do kind of a more complete analysis of this question, there's a big range of estimates, and we've seen anything from 20% to 75%. So I think there's still kind of a good amount of that we're learning about what percent of the cases in general of this disease are asymptomatic. But certainly it looks like from our data here that a lot of them are, 73% of the ones that we know about.
Thank you so much, Dan. Going back to the question list. So this was a two-part question. Where can I find the data for symptomatic versus asymptomatic numbers? Dan just went over that. The second part of the question was, where can I find the recovery rate data for COVID? And this is, we do publish this number. So if you're watching our dashboard, I'm going to share my screen, and you can see on the main dashboard, the overview page, we list the number of cases till date, cumulative list so far. Scrolling down, and then we list the recovered cases. Just want to put the caveat that this is an estimate. because we do case and contact tracing, and we try to follow up where we can to understand how many people have recovered. They don't no longer have symptoms. But as you can imagine, we do not get a hold of everyone. People do not answer their phone calls. We don't have a good number to reach them. So what we've done is we've made an estimate based on comparing what CDC and others are recommending. So we estimate the number of recovered people based on who was tested more than 14 days ago. So the assumption is that if you've been tested more than 14 days ago, or your symptoms started more than 14 days ago, you have most likely recovered unless you are hospitalized or deceased. So that's how we are reporting how many people have recovered. Again, keep in mind this is an estimate. The numbers are probably close to it, but not exactly exactly that. All right, last two data questions that were submitted. The second last question, number 11, is the adjusted case rate per 100,000 the little number or the big number? And again, thank you for asking this question. We realize that it is kind of hard to interpret which one is the adjusted rate. So I'm sharing my screen again. As you can see, 28.6 cases per 100,000. That's the actual unadjusted rate of cases per 100,000. And the adjusted rate is 24.9. And if you haven't been following this closely, what adjustment really is that the state is comparing the amount of testing we do in our county against the statewide median. So if we are testing more in Contra Costa compared to the statewide median, the state will adjust our case count a little bit lower. The argument behind that is that because we are testing more, we are likely to discover more cases. So they give us that credit and they adjust it lower. The reverse is possible too. If we test less than the statewide median, they will adjust our cases up because just because we're not testing doesn't mean the cases went away. So that's the argument the state has made, and they've created this formula on how to calculate the adjusted rate, and that's what the state had been using and is still using for the blueprint for reopening. So the answer is the big number is the unadjusted and the small number is the adjusted rate. And the last question is the data question that was submitted was, please update all the charts to include December 3rd. It looks like omitting data is intentional. This was submitted on December 3rd. So as I explained previously in my slide, it takes us a day to get the data. That's why you will see we don't have the current day's data. We only report the previous day's data. And also on some of the charts, we gray out the last few days because there could be delays in reporting from the lab to the state. So the numbers for the last few days are not final yet. So that explains why the data was not there for December 3rd on December 3rd, but it's there now. We had a few other non-data questions, so I put them here. But Kim, given this is a data session, should we just see if there are any other data questions before we go to the non-data questions?
Yeah, I mean, I think what we're here to talk about today is data. And I know I have one question in the Q&A, and then I know that there are some in chat, so we'll try to get those. But also, if you would rather ask your question in person, please feel free to raise your little yellow hand virtually. But let's start with the one that I have in Q&A. So I see that Santa Clara shows the LTCF with current outbreaks. I believe they use their contact tracers to populate their list. What is the reason that CC does not show that level of data? We know that there are outbreaks, but we don't know where. I appreciate your transparency by having these sessions.
So this is more a policy question. Kim, do you want to address it?
Do you want me to take it? Yeah.
Yeah, go ahead.
Yeah. So in case you don't know, the county doesn't in any way regulate long-term care facilities. So these would be congregate living, skilled nursing, those kinds of settings. So our role in those facilities really is to be a consultant around infection control and helping them get PPE if they need it and that kind of thing. But it really is the state that regulates and licenses those facilities. So what our website does is actually point to the data on the state site, because we feel like putting it on our own website is duplicative and also very hard for us to maintain in a consistent basis. So so the information is there. It's just it just points to the state site. So that is the answer to that. And the same person has just raised their hand, so I'm going to allow them to talk, and let's see what else they have to say. So this is Peter Schmidt. Go ahead, Peter. We'll need to unmute yourself. Let me see if I can do that. Peter,
Unmute. All right.
there you
Can
go.
you hear me?
We can.
Okay, great. So yeah, thanks for having this session. I really appreciate it. I thought that your answer was the answer. I guess I just want to note to you that when you go to the state site and look for any LTCFs that have an outbreak in Contra Costa County at this point, they list none. Yet your data shows that there are, I can't remember the number, but that there are active outbreaks. So there's a data issue there, but I understand that that's a state thing.
But that's good feedback. So Bhumil, maybe you can research that a little bit more, because you're right. We want to point to a place where there is actual data. The last time I looked at it, there were a whole bunch of them, but it's not a super useful list. Like you have to almost download it into an Excel spreadsheet so you can sort it, because it's not alphabetized, nor is it by county. It's just, yeah, but we'll look into that. Thank you, Peter.
Okay, thank you.
Anybody else have any other questions? I think there were some in the chat, so let me take a minute to look in the chat. It's harder to follow the questions in the chat, which is why I asked to put them in the Q&A. But let me sort through what's in the chat, and we'll give it a go. Okay, we have somebody who's here listening because they're grocery shopping. Hi, Wendy. Okay, so Wendy says, I submitted my question via email, but wondering about the discrepancy in the long-term care facility dashboard recently, where it said, okay, so I think we addressed that question. May have been a glitch. Okay, so we addressed that one. You might not know this because it's not a data question per se. The staffing issue due to lack of funds to hire nurses and doctors because they lost so much money when we flattened so hard that hospitals were empty. My friend's brother is an ER doctor just finishing residency, and his class cannot find a job. They're looking all over the country, ER docs. Yeah, that's not an issue that I think we can address here. And certainly, I mean, Bhumil, you don't have any insight into that. Yeah.
This is the reality. So
yeah. And then Peter's question about the long-term care facilities.
I have one more question.
Oh yeah, go ahead.
So I've been looking at it from the city that I'm in. I'm in Pleasant Hill. One of the things I noticed in the data was a big spike in Pleasant Hill specifically. And it made me realize that in the city data that you guys have, although you have static 14-day totals, by looking at it, you wouldn't be able to tell, for example, that Concord's on the way down and Danville's on the way up. So having some sort of metric that says, you know, in the last 14 days, or, you know, the trend is up 85%, or something that reflected the level of change for those particular places would help us know, you know, it's a problem here now instead of it's a problem somewhere else.
sure. Yeah.
I see Dan making a face, but go ahead, Bhumil.
Go ahead,
Yeah, I think that my face was mostly that. I mean, I think that's a good idea. I think we would want to be careful about exactly how we communicate that information and how we tracked it, to make sure that when we say, you know, rates are going up in this place and rates are going down in a place, we're actually, you know, reflecting true differences in risk and not kind of just the random variance that happens over time. Especially when we're looking at small geographic areas, you get in a little, you know, it's just a little trickier to identify trends. But yeah, that is certainly something that we do look at internally, kind of changes over time at locations, and I think that's a good idea, you know, to be able to share that in some kind of, you know, defensible way to the public. I think that's a good idea.
Yeah, it makes sense that you would want to be careful about it. It's also, yeah, it's good that you guys are tracking it. I do think it's useful for us because, you know, like I have conversations with people and say, hey, you know, Pleasant Hill's up. And they look at the Pleasant Hill data and they see 82 cases in the last 2 weeks or whatever it is now. And they go, whatever. And I say, well, you know, it was 7 or 12 or whatever it was just 3 weeks ago. So
We
Yeah,
have
that's important
constant we
context.
have constant conversation about how to put our data in context, and sometimes it's easy and sometimes it's not. It's one of the things that Boomil is and his team are really great at. So
great. I appreciate it, guys. Thank you.
Yeah, so we'll make a note of it. We'll see how best to present it without giving a false sense of confidence or false sense of fear, you know, something going on in the community. Because it's also possible sometimes that, you know, we have a large outbreak in a big household, right? So say 12 people live in a household and all 12 get COVID, numbers can shoot up. But so you know, that the context is really important, especially in a small, like say, Pleasant Hill is reasonably sized, but there are smaller cities like Diablo and others, right? So just having
Yeah.
you know, so we need to make sure we provide the right context.
I have a couple of other questions in the chat. So Peter, if it's okay, we'll move on to those. And then if you have additional questions, we'll come back to you. So Wendy says, yes, we are watching the dashboards, hoping to meet goals set by the state and county so we can move more openings, freedoms, but then they keep moving the goalposts. So I guess now we watch the dashboards just because we are nerdy, not because it gives us any hope anymore. It would be so cool if we could start reporting, tracking symptoms, but yes, you're right, that would be hard since symptoms can develop later. I'll just say that we're not in disagreement with you about the changing goals. You know, we've followed the state as closely as we can, and you know, it's kind of an evolving situation all the time, and we're conscious of that. We're conscious of the fatigue that places on our community, and very we feel the weight of that. We know that it's very difficult. You know, we are very happy to report that we will have vaccine in the county, hopefully by Monday, and that it looks very promising. And while it will be a somewhat slow rollout, we're hoping that that's really some light at the end of the tunnel in terms of being able to, you know, really see the data change and move ourselves back to kind of normal life as we recall it. So that's kind of my non-data answer to that. Boomil, is there anything that you'd like to add?
No, it is. I mean, you know, yeah, I appreciate this. All of us are living through the same, and you know, we follow the state closely. I can understand the state's challenges too. So we keep up with what the latest guidance is from the state, and we report back.
Yeah. So next question is why death and hospitalization data is not broken down by age per day instead of cumulative?
Sure. So if you go back to my, you know, the previous first slide I shared, we said all our dashboards have 3 principles, right? As much transparency as possible. Second, as simple as possible. And third is protecting patients' privacy. Death data often, you know, fortunately, we don't have as many deaths in our county. We still have one too many. But given that, you know, one death, if we share what the age is, what city they are from, what race and ethnicity, it starts becoming easier and easier to triangulate and you know, the risk of exposure. And then also in terms of simplicity, right? It, you know, just makes it very complex to display the data by day, by week, overall cumulative. All this we track internally. We are constantly tracking where, you know, where the highest disease burden is, you know, in the community. So we do share the data cumulative by age, but you know, we don't do it by day for every day for the reasons I mentioned.
So one more question kind of along those same lines. Why aren't data divided into care facilities and individual households?
Oh, we do. So, you know, I answered the question. So if you go to the long-term care facility dashboard, the cases you see there are all cases associated with a long-term care facility. And every other case is tied to the community. So this could be one individual in a household or could be multiple individuals in a household. But that's how we break it down. Anything that's not associated with a long-term care facility are cases in the community.
So Wendy says, thank you. She has 2 teens and a 12-year-old, and it's been hard. Yes, we Wendy, we all feel that, and we have a lot of compassion for that. I totally understand. So this is a bit of an aside question, but I appreciate it. You all can chime in as you like. So she asks, curious, what did you all do before all this, since this seems like such a big focus and time consuming? What's our normal job? I'll just say for myself, I actually started my job at Contra Costa Health Services on the day that we issued the first shelter-in-place order back in March. So I have no concept of what my job is outside of COVID. But Bhumil and his team have been around, and so I'll turn it over to you guys and let you talk a little bit about what your normal life looks like.
Thanks, Wendy. It seems hard to imagine what normal life was. It was 9 months ago. But even we obviously, this is the top priority for the county health department, is to make sure that we avoid unnecessary deaths and hospitalization, and at the same time get the county back to normal, in air quotes, as soon as we can. Our team, and some of you can see on the call, we do, as public health, part of public health, we are responsible for all the surveillance, reporting, providing insights to our health officer, as well as the community. But if you know, the county health department has a hospital in Martinez. We have a number of clinics across the county. So we provide care, both outpatient as well as inpatient and emergency room. County also has a health plan with 200,000 members enrolled in it. So, the public health department in non-COVID time, and even in the COVID time, is proactively working in the community COVID is not the only disease in the community, right? There are other diseases too. So proactively works in reducing, sexually transmitted diseases, addressing some of the social factors which affect health outcomes. So this team provides that data insight and assistance for the care delivery, both in the hospital, clinics, in jail, as well as doing all the financial reporting for tracking our membership and claims. There's, as you can imagine, a lot of our funding comes from the state and federal government. So we have to have very high level of oversight and reporting back, because it's all public money. We have to have transparency. So that's a number of things we do outside of COVID.
You might remember that in times before COVID, there were, you might have heard media stories about, measles exposure, or, I remember when I first moved to California, there were lots of ads about pertussis, and which is whooping cough outbreak, and so this is the team that really is on the front lines of seeing those outbreaks and doing what they can from a public health perspective to keep them from, becoming widespread in our community. So, the work that they do really drives sort of the preventative decisions that are made. So it's very important. And I'll tell you what, they are as dedicated as anybody I've ever seen. And we ask them for a data point, and 20 minutes later, sometimes it feels like there it is. And so we really appreciate that, and appreciate the question, Wendy. So is there anything else? I really think that these policy questions, we'll take those and answer them in other venues. I don't think that we're the best people to really take on those questions. So we will note those, and then we will kind of take those back and answer them in other venues. It looks like Wendy has one last question. Do you know if the county is working on a system to track suicides? It is my understanding that we do not track that in our county. So we actually do have some suicide data available. It comes from the coroner's office. And so Bhumil, I don't know if you want to talk about this specifically, but the one thing I will say about the suicide data is that it takes us a while to get it. And so every now and then we'll request the data from the coroner's office and keep an eye on it. And we have not, while we understand the significant emotional impact of COVID and shelter at home and isolation, we have not seen a consistent trend across the shelter in place in the COVID outbreak where suicides are concerned. There's always fluctuation month to month, and quite frankly, one is too many, but we have not seen a consistent increase in the number of suicides in Contra Costa County. So Bhumil, anything else you'd like to add to that?
Actually, Lisa and Dan put together some, the data we are tracking. Again, we are happy to be very transparent and share. So if we can take a couple of minutes that we can show you the data that we have been tracking about suicide. 1 second. Dan and Lisa, you want to go over this?
Sure, I can, since I put it together. So this is just a comparison between the cumulative suicides in 2019 through 2000 and 2020. So 2020 is in orange, 2019 is in blue. And you can see that we were outpacing 2019 even before the pandemic. In January and February, we were above. And now we're about equal. I will say that some exactly what Kim said about suicides being coroner's cases. Sometimes they take a little bit longer to be reported to us. So I think that certainly that November and possibly the October numbers for the 2020 orange might creep up a little bit, but you can see that they're very similar to what they were in 2019. So we're not seeing a huge increase in terms of suicide deaths. Now, this again is just suicide deaths. So this is not attempts. That's much harder to get at, but you can see that in terms of loss of life, we aren't seeing a big jump compared to last year. And you can see that that's pretty clear even across the time of the pandemic and since we've been sheltering in place. And to your earlier questions, we do part of, as Bumil said, part of public health core functions is doing surveillance. So even during COVID times, we are looking at what people are dying of. We're looking at if there's anything bumping up that we need to be aware of. We haven't dropped absolutely everything to do COVID, although it has been a large part of our work in these last few months.
One other thing I would share related to that might be of interest to a group like this is that before COVID came along, Contra Costa Health Services was engaged in a sort of a visioning process, a health visioning process that we're calling Living Contra Costa. And it really was it was a look at the holistic role of health in people's life. And so there are a number of dashboard elements in that process as well. And we're looking at how in the world of COVID, we can start to roll that out and really look at the strategic role of healthcare in our community here in the not too distant future, we hope. And so I knew, Bumil, you were way more involved in that project than I was. Is there anything you'd like to say about that effort?
Yeah, I mean, I think there's a key, we as a health system, we track a number of things, right? How many of our patients are falling behind on the diabetes, haven't been screened for, say, breast cancer, and so on. And these are all clinical outcomes we are tracking. We're also tracking, as Lisa said, the disease prevalence. But one question we asked ourselves and the community before COVID started was, what truly matters to the community? Because A1C rates and blood pressure rates are important from a provider clinical perspective, but to live a good, happy life in the community, what do we need? So we started this year-long exercise where we had multiple sessions, town halls from across the community. We heard what matters. And then based on that, we started this project called Living Contra Costa. It's an ambitious project, a goal that, by 2050, we become one of the most healthiest community to live in. And for doing that, we'll have to have to live well, live healthy, live safely. And under that, we are building a dashboard to track what does living safely mean, like what's our crime rate, domestic violence, and so on. What does living well mean? So what's our air quality like? A number of hours people spend in a commute driving. So before COVID, you remember, we used to have nightmarish traffic on 680 and Highway 4, right? So that all affects our quality of life. So we that's an ambitious project. It's still, unfortunately, we had to obviously reprioritize COVID work, but it's still, we are still moving it forward. So the goal is to share with the community where we stand right now on what would help us live a happy, healthy life, and then how can both the county government as well as private sectors as well as the public can work together to improve our outcomes, with the goal that that by 2050 we do become one of the healthiest community to live in the entire nation.
Okay, I think that is all. Last chance to raise your hand if there's anything we didn't cover that you were hoping we would. Otherwise, we will say enjoy your weekend and thank you for joining us.